Diseases of ear, nose, and throat by and head and neck surgery by P.L. Dhingra. Chapter 6 Assessment of Vestibular Functions, Part 2 of 2. Where L30 is the response from the left side with water at 30 degrees Celsius and L44 is response from the left ear after stimulation with warm water at 44 degrees Celsius. Less or no response from a particular side is indicative of depressed function of the ipsilateral labyrinth, vestibular nerve or vestibular nuclei, and is seen in Meniere's disease, acoustic neuroma, post-labyrinthectomy, or vestibular nerve section. B. Directional preponderance. It takes into consideration the duration of nystagmus to the right or left, irrespective of whether it is elicited from the right or left labyrinth. We know that right beating nystagmus is caused by L30 and R44, and left beating nystagmus is caused by R30 and L44. Therefore, R being nystagmus R beating nystagmus is equal to L30 plus R44 divided by L30 plus L44 plus R30 plus R44 into 100. Left beating nystagmus is equal to R30 but plus L44 divided by L30 plus L44 plus R30 plus R44. If the nystagmus is 25% to 30% or more on one side than the other, it is called directional preponderance to that side. It is believed that directional preponderance occurs towards the side of central lesion, away from the side in a peripheral lesion. However, it does not help to localize the lesion in central vestibular pathways. Canal paresis and directional preponderance can also be seen together. Canal paresis on one side with directional preponderance to the opposite side is seen in unilateral Meniere's disease, while canal paresis with directional preponderance to ipsilateral side is seen in acoustic neuroma. Cold air caloric test. This test is conducted when there is perforation of tympanic membrane because irrigation of water in such a case with perforation is contraindicated. The test uses the Dundas Grant tube, which is a coiled copper tube wrapped in cloth. The air in the tube is cooled by pouring ethyl chloride and then blown into the ear. It is only a rough qualitative test. Electronystagmography. It is a method of detecting and recording nystagmus, which is spontaneous or induced by caloric positional, rotational, or optokinetic stimulus. The test depends on the presence of corneoretinal potentials, which are recorded by placing electrodes at suitable places round the eyes. The test is also useful to detect nystagmus, which is not seen with the naked eyes. It also permits to keep a permanent record of nystagmus. Optokinetic test. The patient is asked to follow a series of vertical strips on a drum moving fast from right to left and then from left to right. Normally, it produces nystagmus with slow component in the direction of moving strips and fast component in the opposite direction. Optokinetic abnormalities are seen in brainstem and cerebral hemisphere lesions. Thus, this test is useful to diagnose a central lesion. Rotation test. The patient is seated in Barani's revolving chair with his head tilted 30 degrees forward and then is rotated 10 turns in 20 seconds. The chair is stopped abruptly and nystagmus observed. Normally, there is nystagmus for 25 to 40 seconds. The test is useful as can be performed in cases of congenital abnormalities where ear canal has failed to develop and it's not possible to perform caloric test. Disadvantage of the test is that both labyrinths are simultaneously simulated during the rotation process and cannot be tested individually. The test has now been made more sophisticated by using torsion swings, electronystagmograph, and computer analysis of the results. Galvanic test. It is the only vestibular test which helps in differentiating an end organ lesion from that of a vestibular nerve. The patient stands with his feet together, eyes closed, and arms outstretched, and then a current of 1 milliampule is passed to one ear. Normally, the patient sways towards the side of a nodal current. The body sway can be studied on a special platform. Posturography. It is a method to evaluate vestibular function by measuring postural stability and is based on the fact that maintenance of posture depend on three sensory inputs: visual, vestibular, and somatosensory. It uses either a fixed or a moving platform. Visual cues can also be varied. The clinical application of posturography is still under investigation. Dynamic visual acuity test. This test is more useful in patients who complain of ossiculopsia, that is, inability to read boards and hoardings while walking. This is due to bilateral vestibular loss as occurs after therapy with vestibular toxic drugs like streptomycin, gentamicin, etc. To perform this test, the patient reads a Snellen's chart and his visual acuity activity is recorded. He is then asked to move head right and left horizontally at a frequency of 2 Hz and again read the chart during movements. A patient with normal vestibular function may get a decline of one line, but those with ortholopsia may show decline of up to 5 lines. During the procedure, the patient should wear his corrective glasses or contact lenses. It is a bedside test and helps to detect early toxicity to vestibular organs. The vestibular thrust and this test should be performed daily in patients receiving aminoglycoside antibiotics. Vestibular evoked myogenic potentials (VEMP). This is a test to study function of otolith organs, the saccule and utricle. Normally, their function is linear acceleration. They can also be stimulated by loud sound of air or bone conduction. Even tapping the head can stimulate them. Myogenic potentials can be picked up from either the sternocleidomastoid cervical muscle or ocular muscle, inferior oblique or superior rectus, and have respectively been called C-VEMP or O-VEMP. Since saccule is supplied by inferior division of vestibular nerve and utricle by the superior division, the study of VEMP in neuroma can help us to find its origin from the superior or inferior divisions. Reflex arc is from saccule, inferior vestibular nerve, vestibular nuclei, ipsilateral vestibulospinal tract, spinal accessory nerve, cranial nerve 11, sternocleidomastoid. From utricle, superior vestibular nerve, vestibular nuclei, medial longitudinal fasciculus, oculomotor cranial nerve 3, inferior oblique and superior rectus muscles. Air conduction conducted sounds primarily activate the saccule, while bone conducted sounds activate both the saccule and utricle. WEM study is being used clinically and the equipment is also available but needs further research. WEM is being used to find the origin of acoustic neurons from superior or inferior vestibular nerve, Meniere's disease, superior canal dehiscence, vestibular neuritis, and localization of lesions of posterior cranial fossa, that is from the upper and lower brainstem. Vestibular ocular reflex is mediated through upper brainstem, while vestibular spinal arc is through the lower brainstem. WEM studies are still in investigative state. Thank you.